evening and welcome to a very special program on Unburdening Asthma, Simple Insights into Challenging Problems. This program is presented in partnership with BlackDoctor.org, the African American Wellness Project, and AstraZeneca Pharmaceuticals. I'm Dr. Mike Lenore, president of the African American Wellness Project. Asthma is my passion, and I'm personally excited to have as our guest Dr. DeMons Haynes. I personally can do no justice to introducing Dr. Haynes, so I'll let Dr. Haynes introduce himself.
Hello, and welcome to this program sponsored by AstraZeneca. I have the pleasure of providing this educational disease state presentation. My name is Dr. DeMons Haynes. I'm a pulmonary and critical care specialist at the University of Mississippi Medical Center, where I am also the Associate Dean for Admissions for the School of Medicine. Please note this presentation does not qualify for any form of continuing education credit. Thank you for joining this presentation entitled Unburdening Asthma, Simple Insights into a Challenging Problem. Today, we aim to achieve the following objectives. Realize the burden of asthma in the United States and the role that severe exacerbations play in disease morbidity. Understand how variability in airway inflammation places all patients at risk of symptoms and severe exacerbations. Recognize the relationship between acute treatment of exacerbations with systemic corticosteroids and long-term risk of adverse health conditions. And finally, review Global Initiative for Asthma and National Asthma Education and Prevention Program recommendations for treating symptoms and inflammation concomitantly to prevent morbidity from severe exacerbations. Let's start by taking a look at the burden of asthma in the United States. In 2019, there were approximately 25.1 million people living with asthma, with an estimated 10.3 million annual asthma attacks. Data from the Centers for Disease Control and Prevention in 2018 showed an estimated 1.6 million annual emergency department visits and 180,000 annual hospitalizations due to asthma. What has been less obvious is that despite recommendation and therapy changes, the rates of adult asthma attacks and emergency department visits have remained largely unchanged. We speak of burden as if it is universally shared, but is it? The burden of exacerbations in the United States was greater when compared to other North American and European countries. Let me repeat this. The burden of exacerbations in the United States was greater when compared to other North American and European countries. The short-acting beta-2 agonist use in asthma global program, otherwise known as SABINA, is the largest real-world data analysis of clinical outcomes related to short-acting beta-2 agonist, or SABA, use and maintenance therapy in asthma. This program comprises an innovative framework of harmonized, large-scale observational studies across 40 countries. Shown here are the results from the observational analyses of SABINA data sets involving approximately 1 million patients greater than or equal to 12 years from countries in Europe and North America. Both the mean number of annual asthma exacerbations, as shown in this bar chart, and the use of SABA monotherapy were greater in the US. And it is important to emphasize that increased SABA utilization is associated with increased exacerbations. Again, increased SABA utilization is associated with increased exacerbations. The data in the preceding slides suggests that the United States may need to change how it approaches asthma from the ground up. Let's start with a fundamental understanding of asthma. Airway narrowing in asthma is due to smooth muscle constriction and inflammation-induced airway swelling, both contributing to airway narrowing and asthma symptoms. Airway inflammation and symptoms vary over time and in intensity and lead to asthma exacerbations. Now that we have discussed the role of inflammation in producing symptoms and exacerbations, let's review how the absence of symptoms is not the absence of disease. To illustrate this concept of inflammation being poised to lead to an exacerbation, let's look at an endobronchial biopsy from a patient without symptoms. The biopsy shows evidence of epithelial disruption, thickening of the basement membrane, and extensive eosinophilic and lymphocytic infiltration. Even in patients with mild asthma, the risk for serious adverse events is high. Up to 37% of asthma-related ED admissions were in patients with mild asthma. 16% of patients with mild persistent asthma and 60% with intermittent asthma have been found to have had one or more exacerbations in a previous year. So again, the absence of symptoms is not the absence of disease. Now let's delve into the pharmacotherapeutic roles of short-acting beta-2 agonists and inhaled corticosteroids in asthma. Short-acting beta-2 agonists, or SABAs, address symptoms, but not the underlying inflammation in asthma. SABAs provide direct agonism by binding to beta-2 adrenergic receptors, producing airway smooth muscle relaxation. With inhaled corticosteroids, or ICS, we see non-genomic effects which occur within minutes, including amplified beta-2 agonist-induced bronchodilation, decreased bronchial vascular blood flow, and suppressed immune mediators. And we know that genomic effects occur within 4 to 24 hours, including increased anti-inflammatory gene transcription, decreased pro-inflammatory gene transcription, and increased beta-2 receptor gene transcription. So then, how might this information translate into a real-world setting? Despite the real-world use of anti-inflammatory maintenance therapy, the risk of asthma exacerbations is not eliminated. This study by Lugogo et al. Included approximately 135,000 patients with asthma. They looked at the heterogeneity in the amount of SABA canisters being filled, either 1, 2 to 3, or 4 or more per year, adherence to maintenance medication, and the percentage of patients in these categories that went on to have one or more exacerbations. The study found that 71.8% of patients with asthma filled at least 2 SABA prescriptions in the year of observation, indicating that approximately 3 in 4 patients had uncontrolled asthma. Despite higher maintenance medication possession ratio with increasing SABA fills, the percentage of patients within each SABA group having one or more exacerbations rose as SABA fills increased. Regardless of SABA exposure or maintenance medication adherence, roughly half of patients with asthma experience one or more exacerbations per year, demonstrating that all patients are at risk of exacerbations. How did we fall behind in the United States? Well, Murphy et al. Shined a light on the fact that in routine clinical practice, asthma control is overestimated because exacerbation history is not always appreciated. In this study of over 1,000 patients, they found that 32% of patients who assessed themselves as being completely or well controlled had one or more exacerbations in the last year. 30% of patients assessed by their clinician as completely or well controlled had one or more exacerbations in the last year. And finally, 29% of patients classified as well controlled by the asthma control test had one or more exacerbations in the last year. Of note, prior exacerbations are a strong predictor of future exacerbations. So, how can the consideration of exacerbation history help us determine future risk? One path forward might be to integrate exacerbation history into patient assessments in order to attenuate the overestimation of control and to highlight to clinicians and patients the potential risk of future exacerbation. The Asthma Impairment and Risk Questionnaire, or AIR-Q, is an equally weighted 10-item yes-no composite asthma control tool designed to facilitate shared decision-making conversations between HCPs and their patients with asthma. This same study by Murphy et al., when they were further assessed with the AIR-Q, only 15% of patients rated as well controlled had exacerbations in the last year. We see here that this Kaplan-Meier curve demonstrated clear differentiation of time to first exacerbation by baseline AirQ control level. Patients with worsening AirQ control levels experience exacerbation sooner and more frequently throughout the 12-month observation period. The key takeaway here is that all patients with asthma are at risk of exacerbation, regardless of level of control. And too many times, the history of past exacerbations is being missed in clinical practice. Another concept that we may be missing in clinical practice is that treatment of exacerbations with systemic corticosteroids, or SCS, contributes to the burden of disease. Observational data have suggested that standard bursts of systemic corticosteroids may result in a cumulative steroid burden on current and future health. Shown here are the potential risks of developing adverse health conditions due to varying levels of cumulative systemic corticosteroid exposure. The risk of adverse health conditions can increase with increasing cumulative exposure to systemic corticosteroids, with statistical significance evident for most adverse events when progressing from the 0.5 to less than 1 gram cumulative SCS exposure category to greater than or equal to 1 gram cumulative SCS exposure, compared with the reference category of greater than 0 to less than 0.5 grams. In a separate retrospective cohort study and self-control case series, it was observed that within 30 days of oral corticosteroid initiation, the incidence of adverse events such as sepsis, venous thromboembolism, and fracture approximately doubles. You might be wondering, how soon could this happen in clinical practice? Reflecting upon data from the long-term observational study by Price et al., let's take a look at what a typical burst of oral corticosteroids could mean. With one burst, we can reach the 500 milligram threshold. With a second burst, we can reach the 1,000 milligram threshold. And with burst 3, we find that we have likely exceeded the cumulative threshold. Keep in mind, this is illustrative of the use of systemic corticosteroids for asthma and does not include other cumulative exposures patients may receive for the treatment of other conditions. This begs the question, is there a window of opportunity to interrupt an impending exacerbation and the need for systemic corticosteroids? In this slide, we present a figure from the FACET findings, an exacerbation reduction study in response to an inhaled corticosteroid with or without a long-acting beta-2 agonist. This work examined the pattern of peak expiratory flow rate decline and symptom and rescue use increase in the days preceding the 425 exacerbations that occurred during the study. Peak flow fell and symptoms and rescue use increased in the 10 days before the exacerbation was diagnosed and returned to pre-exacerbation or near pre-exacerbation levels over the subsequent 2 weeks. Consequently, there may be a window of opportunity to interrupt the rising inflammation that can result in decreased lung function, increased symptoms, and increased use of rescue therapy, and thus prevent the occurrence of an exacerbation. And if that is the case, how might this align with patient goals? As we see with the INSPIRE study, treating symptoms and inflammation concomitantly is aligned with patient goals. This study examined the attitudes and actions of 3,415 patients in 11 countries, including the United States, aged 16 years or older with physician-confirmed asthma who were prescribed regular maintenance therapy with inhaled corticosteroid, 30%, or inhaled corticosteroid plus long-acting beta-2 agonist, 70%. Structured interviews were conducted to assess medication use, asthma control, and patients' ability to recognize and self-manage worsening asthma. 38% of patients believed that there was no need to take medication every day. 90% wanted immediate relief when symptoms occurred. Although most patients recognized the early signs of worsening, the most common response was to increase short-acting beta-2 agonist use. So then, how does this align with current asthma recommendations? The latest recommendations from the Global Initiative for Asthma, or GINA, and the National Asthma Education and Prevention Program, or NAEPP, support treating symptoms and inflammation concomitantly. Patients with apparently mild asthma are at risk of serious adverse events, which are largely reduced with inhaled corticosteroid-containing rescue therapy versus short-acting beta-2 only rescue treatment. In adults or adolescents aged 12 years and older with asthma, both the 2021 GINA and the 2020 NAEPP recommendations acknowledge that even modest SABA use is associated with harm, including an increased risk of asthma-related death. Strong evidence exists for as-needed ICS formoterol as a safe and effective way to reduce exacerbation risk. As stated in GINA, although inhaled SABAs are highly effective for the quick relief of asthma symptoms, patients whose asthma is treated with SABA alone compared with ICS are at increased risk of asthma-related death and urgent asthma-related health care, even if they have good symptom control. The risk of asthma exacerbations and mortality increases incrementally with higher SABA use, including in patients treated with SABA alone. The NAEPP stepwise approach is meant to assist, not replace, the clinical decision-making required for individual patient management and the input from individuals with asthma about their preferences. For individuals with mild to moderate persistent asthma who are taking daily inhaled corticosteroid, ICS treatment, likely adherent with prescribed daily ICS as a controller, increasing the regular daily ICS dose for short periods is not recommended when symptoms increase or peak flow decreases. Please note, the use of ICS formoterol is not approved for maintenance and rescue therapy in the United States. The recommendations for ICS formoterol are based on clinical data evaluating the use of ICS formoterol formulations and strengths not approved and not available in the United States. An example of the effects of implementing these expert opinion recommendations is shown here in the PREPARE study. High-risk populations of U.S. Black and Latinx adults with moderate to severe asthma continued with their maintenance medication and either used SABA as needed, usual care, or a rescue therapy regimen of as needed SABA and an ICS in two separate delivery devices, intervention. In patients in the PREPARE study, as needed SABA plus ICS versus SABA as rescue decreased the risk of severe exacerbations by 15.4%. Additionally, in the as needed SABA plus ICS group, there was a reduction in the number of missed days of work, school, and usual activities, and an improvement in asthma control as measured by the asthma control test. As we come to a close, let's review the key conclusions from this presentation. The burden of asthma in the United States is high, with severe exacerbations being a key component of morbidity. Inflammation is a smoldering feature of asthma that varies in intensity over time and places all patients at risk of symptoms and severe exacerbations. SABA treats the rise in symptoms that often precede a severe exacerbation, while ICS is needed to treat the underlying escalating inflammation. As few as 2 short courses of systemic corticosteroids used to treat exacerbations can result in long-term adverse health conditions. And finally, a window of opportunity may exist to prevent a severe exacerbation if symptoms and inflammation are treated concomitantly, as expert opinion reports suggest. Thank you so much for joining me for today's presentation. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have comments that could improve the delivery of our promotional educational programs, please contact AstraZeneca at 1-800-236-9933. This concludes this presentation.
Well, thank you, Dr. Haynes, so much for that presentation and that interesting information. but we don't often get someone of your caliber to discuss asthma with our communities. So we want to take full advantage of that opportunity. First of all, African Americans are very concerned about the outcomes, disproportionately sicker and disproportionately dying more often. Tell us the extent to which asthma affects our country, and tell us about your initiative.
Thank you so much, Dr. Lenore. I'm so happy to be here with you all this evening. As was mentioned on one of those first few slides, we have significant burden from asthma in this country in morbidity and mortality. And as you mentioned, African Americans suffer a great deal from that as well. If you look at the number of days lost from school and work, it's really significant. If you look at the number of deaths, that first slide that we talked about, talking about the burden, over 3,500 deaths in this country each year in asthma, and a little less than 200 of those are in patients who are 18 years of age or younger. And so it's really concerning whether you're looking at time lost from school, time lost from work. And of course, we know most times, particularly in our community, students who lose time from work will cause their parents or guardians to lose time from work because they have to be there to care for them. So it's a significant burden in this country on our patients and our community.
We hear the term asthma thrown around, but I'm not sure people actually know what asthma is. Tell us a little bit about exactly what asthma is and how it affects the lung.
So the biggest two components for asthma is it causes inflammation. So you probably have heard of that term, inflammation, in the airways. And it also causes what we say bronchoconstriction, meaning tightening of the airways or squeezing of the airways. And that is the biggest thing, is that asthma is affecting it. That causes the patients to have shortness of breath. When you can't, that inflammation leads to the constriction or the tightening of the lungs. So when you have the tightening, you can't get that air moving. You have problems with what we call airflow. That makes them short of breath because you cannot get that air to move.
Many people focus on treatments, focus on the airway closing down, but there are many different components. What are some of the causes of this closing down, or maybe what are some of the treatments?
So for treatments for asthma, of course, we use inhaled corticosteroids, which really attack the inflammation that's going on in the airways. And then we use the bronchodilators or the rescue inhalers that most people would talk about, it, whether it be albuterol, Provenal, has a lot of different names. But the rescue inhalers help open up those airways so that the air can flow better. If you're having what we call an asthma exacerbation, most times the mainstay of treatments for those patients we're giving systemic steroids or oral steroids. People talk about prednisone. Prednisone has a couple of different names, but that's the generic name for it. It may be a shot in the IV, or it could be pills you're taking by mouth. Those things, when you're in an exacerbation, you might continue to still use your inhaled medicine, but you really need to then also be on an oral steroid.
In your discussion, you talked a lot about exacerbations, and I'm not sure people caught what that means. More importantly, how should a person know when their asthma is well controlled?
So that's a great question. Some people think that they know their asthma is well controlled because they're not using albuterol, but that's not it. We need some validated ways of assessing asthma control. And one of the things that I talk about on the presentation is the AirQ, which is a validated score, 10 questions, very simple, written on a 5th grade level. You can obtain it from if you go online, it's airqscore.com. It's available in English and Spanish. And so it actually walks you through a set of questions. The physicians or the providers, the clinicians can answer questions for a patient. The patient can answer questions. And like I said, it's very simplistic and it doesn't take much time to fill out. That's really the best way because sometimes patients don't know that they're not having good control over their asthma.
When you talk about the utilization of that test, how important is it to do it on a regular basis so you can keep track of some of the numbers?
That's exactly right. So not just when you are having a flare or an exacerbation. I probably should have said that because some folks won't know, an exacerbation, a lot of times my patients commonly refer to it as a flare. So you want to talk about the fact that using it on a regular basis can really help you assess your control. And if you're not feeling well, of course you want to use it then too, but really doing it on a regular basis would really help you have a better assessment of control.
of the issues that I see clinically in my own practice is people talk about, well, I only have asthma when I exercise. And so then many of my colleagues say, well, that's exercise-induced asthma. Most of the patients that I've lost through the years have been patients who said they just had exercise-induced asthma. What exactly is exercise-induced asthma? And is it most often poorly controlled regular asthma manifested by exercise?
That is a very, very good question, right? Because when we look at asthma, it can be exacerbated or worsened by many things, right? Those who have intrinsic asthma, it would be worsened by exercise, viral infections, cough, cold, weather changes. Those with extrinsic asthma that might have the more allergic issues, right? They're talking about pollens and things of that nature. So probably people are using that exercise-induced as a misnomer. Probably the majority of those patients had uncontrolled asthma. And realizing one of the things we talked about in the presentation is that all patients are at risk of exacerbations, regardless, even if they had mild to the severe. All patients with asthma are at risk of exacerbations.
You know, you talked about several ways to measure control. You talked about the test that you just mentioned. Certainly there's spirometry, there's nitrous oxide and other things. But, you know, I've kind of broken it down into how much albuterol is that patient using. Tell us about the importance of albuterol usage in measuring control, and how is that a good thing or is that a dangerous thing?
It is a dangerous thing. I'm glad you asked that. It's not the thing we want to use to assess control. As you saw from some of the data, increased SABA use or increased rescue inhaler use is associated with increased asthma-related deaths. It's associated with increased problems. On top of that, you know, in one of the studies that we talked about there, almost 40% of the patients didn't want to use something on a regular basis. 90% of the patients said, I want something that works quickly when I'm having an issue. So using SABA as the assessment of control is absolutely the wrong way to go. We really want to encourage people to get away from that. And I'll go back to the airqscore.com. If you go there, that is going to be a good way to help with assessing control. And remembering that, again, all of our patients with asthma are at risk for exacerbations.
You know, so many people, I think, at least an increasing number of people, are using albuterol across the counter. How do you feel about that?
I'll tell you my personal preference. I really am against it. You know, there was at one point in time many years ago where they pulled it off, right? That Primatene Mist and some of those. And now those things are available again. It again, to me, is a problem because at least if you come to me and you see me in clinic and say, I need refills of my albuterol, it's not the best way to assess control. But I know for sure if you come in and you tell me I've used 3 albuterol inhalers this month, it's a problem. And I can't get that information if you're using inhalers over the counter. I know that increased albuterol use is associated with increased death, so I can spend a little more time with the patient. And that's one of the biggest things as a specialist I do is spend more time educating patients, listening to patients, and trying to get them to understand why we're prescribing something, not just giving them a medicine and hurrying them out the door, as some folks might do, or they may feel doctors do, to tell them this is why I'm talking about this. So those over-the-counter ones really, really cause me a lot of headache and a lot of grief.
You know, I'm certainly in a different era than you are, and I'm amazed now at how many options we have as clinicians to treat patients with asthma. One of the bigger problems, though, is that it's difficult to deal with patients if they're not doing what you told them in the first place. Now, we used to call that not taking your medicine, but that's not the proper term now. We're talking about adherence.
That's right.
Tell us about the importance of adherence, and how do you get patients to move in that direction?
You know, that is such a great question because that is the thing that we know can help patients, right? If they're adherent with therapy. But it's hard. It's particularly hard in my young patients. When they feel good, they don't want to take anything. They want to take it when they have an issue. And so I really spend, again, a great deal of time. And you know, I consider it if I even get through to 1 or 2 patients, I've made a difference. But I spend a great deal of time really explaining to them, this is why we are taking this medication. If I have them on a medication, ICS LABA, this is why you have to take this twice daily or once daily or whatever it is. And really trying to spend that time to them explaining the reason that they're taking it so that they don't just feel like they're taking it and they feel good. And I spend a great bit of time, I know I've said it several times this evening, but I spend a great deal of time with them telling them about the fact that the data show that you are at increased risk of an exacerbation, even if you're doing well. So we need to maintain some level of control. And as I talk to you, all my colleagues, I talk a little more about that inflammation that's present even in somebody who feels well when we look at that endobronchial biopsy. And the patients, I just say, hey, we know inflammation is going on in there, even though you feel well, and trying to convince them that they need to be on the medications. And I spend a great deal of time talking to them about, are you having side effects? Tell me a reason you might not want to be taking this medicine. And then they may tell me about the sore throat that they would not have ordinarily told me about. And I talk about thrush and things of that nature. So I want to spend a great deal of time saying, tell me why you don't want to take this daily.
Dr. Haynes, I think we've stolen enough of your time. Obviously, there's so much we would like to cover, but we've only been given a defined period. Tell us some of the resources that people can use who want to know more about their asthma, something so critically important that's available to patients.
Yep. And I think probably the biggest thing is assessing control. And that, again, goes to the AirQ score, AirQ questionnaire is airqscore.com. Like I said, it's available in Spanish and English, and it is written on a 5th grade level. So, and it's 10 questions, and you can take it, and I bet you, I've done it. You can go through those 10 questions in about 30 seconds. So it's not going to be time consuming for the clinician or for the patient. And so I think that is probably one of the best things. And don't forget to call your clinician, your doctor, your nurse practitioner, PA, whoever you're seeing. If you even think you're having issues, call them. But what we really want to know is we want to assess control, and that's where the AirQ really helps us.
Dr. Haynes, I've got so many other questions to ask you, but our time is relatively limited, and I'm getting some direction on the clock. I really thank you so much for joining us and taking your time today. I also like to thank the AstraZeneca Pharmaceuticals for providing you as a resource for a very meaningful problem that impacts not only every community, but especially the African-American community. I'd like to thank BlackDoctor.org for partnering with us in the African-American Wellness Project. And I always try to remember to say something at the end of all of the programs that I've been involved in, is that health is your biggest asset, so protect it.